Good evening. Welcome to the Healthy Lifestyle Talk for February. My name is Joy Engblade. I'm the Chief Medical Officer here at Northern Inyo, and this is part of our Healthy Lifestyle Talk series, which is a monthly series of educational talks for our community. So in recognition of Heart Month, we'll be talking about the heart and exercise. And I'll be joined by two guests, one of whom, Dr. Rowan, is battling some icy roads in Reno right now, so is a bit delayed in terms of joining us. And so we'll introduce him when he's able to join. I'm also joined here by Adam Maxwell, who is one of the Northern Inyo physical therapists. Adam is from Salt Lake City. He trained at the University of Utah, where he obtained his doctorate in physical therapy, and he joined Northern Inyo last year. So welcome, Adam, and thanks for being part of this talk.
Yeah, happy to be here. Thanks for sponsoring this conversation. It's super important.
So I think, I had some questions and talking points prepared for both Dr. Rowan and for Adam. But while we're waiting for Dr. Rowan to join, I did have some very specific questions for you from a physical therapy standpoint. And for the audience, please feel free to either enter your questions in the chat at any time or just unmute yourself and ask questions. Adam is opening himself up for any questions PT related. But I think the first question I have, and the one that I often get asked by friends and colleagues, is, a lot of us have really busy schedules and we're not able to exercise regularly. So in terms of the heart and cardiac health, is there danger in being what we call the weekend warrior? So only exercising on weekends? Is there any danger in that?
Yeah, it's been an interesting topic lately, especially as I became a father recently. It's something that I've considered. It's like, how do I squeeze in time to keep myself sane, healthy, balanced, and still pursuing my own personal hobbies? So I'm definitely what you would consider a weekend warrior at the moment. I work 4/10s and then have to play my butt off on the weekend to get everything else balanced. And actually, it used to be considered pretty dangerous to do, that there'd be such a large imbalance. But there's been a recent study in the last couple of years that came out that shows that, first of all, the American Heart Association recommends that we get 150 minutes of moderate exercise each week. Moderate being going for a brisk walk, doing some gardening, taking the dog for a walk, light stuff, biking slowly, playing tennis with friends casually, or doing 75 minutes of vigorous exercise, things like walking up a hill with a backpack on, pedaling your bike pretty hard, going swimming in laps, dancing, and really getting kind of sweaty. So 75 minutes of that. Is it better to be paced throughout the week? Or is it okay to get that in a single session, or maybe even 1 or 2 sessions on the weekend? What they've recently found is that there's a reduction in risk of cardiovascular event if you're getting it throughout the week or all in 1 session or 2 sessions. So there's a little bit of a caveat with that, in that if you haven't gone exercising or hiking, probably don't go try and hike Mount Whitney for the first time as your hike. With all exercise, do a slow progression into it. But if you're regularly exercising most weekends, being a weekend warrior is way better than doing nothing at all, and has been shown to not necessarily increase your risk of having a heart attack.
And so, you talk about moderate risk moderate exercise versus kind of more strenuous exercise. I presume you're kind of talking mostly about aerobic exercise. Is there a role for resistance training or anaerobic exercise? Is that good for your heart, bad for your heart? Not sure.
It's a good question. So within those aerobic recommendations from the American Heart Association, they also have tacked on more recently 2 days a week of resistance exercise training as well. What that really does, so groups that in research that have done only aerobic exercise have gotten much better at their cardiovascular health. Groups that do strength training get stronger, so stronger muscles, stronger bones. And then groups that do both have the greatest benefit of everything. So really, we need strength in order to do everything that's important to us, to get off the floor, to when you drop your remote under the couch, being able to carry heavy groceries. Strength training increases the bone density. So if you were to have a fall, you're less likely to have a fracture. So there is benefit for your cardiovascular health as well as just your global health for adding that 2 days a week of resistance exercises as well.
And so does the same kind of hold true for things like yoga or stretching or other things along those lines?
Yoga, I think, is great. My heart rate gets up when I do yoga. For aerobic health, we really want to be doing movement that's rhythmic and continuous in order to ask our heart to be pumping blood continuously. I think stretching is good. If it feels good, do it. I'm super biased to being more like, you should probably be lengthening your muscles with a weight in your hand so that you're getting stronger while you're getting limber. That's my personal bias. But if you'd like to stretch, do it. If your heart's getting up while you're doing it, great. If it's not, I would suggest maybe moving a little bit more.
And getting that heart rate up.
Yeah.
And I see that Dr. Rowan has joined us from the car. This seems like a sketchy situation on icy roads.
Well, wait, Joey, when you're doing 5 miles an hour, it's okay. Yeah, the giant snowstorm that's going to hit you guys, I guess, tomorrow. I heard one of my patients said maybe a foot of snow in Bishop tomorrow, which is should be interesting. It's hitting here, and so that's why I'm late tonight, because I'm just limping my way home from the hospital. So I apologize for being late.
Oh, no, I appreciate you joining from the car. Are you sure that you want to, are you okay to kind of have a talk while you're going 5 miles an hour?
Oh, yeah, absolutely.
Okay.
I'm about 5 minutes away from home. I just want to keep you guys waiting.
That's okay. So for everyone else who's joined, obviously this is Dr. Rowan. Dr. Rowan lives in Reno and is going 5 miles an hour down the interstate. Dr. Rowan is a cardiologist, a board certified cardiologist, currently working at the Renowned Institute for Heart and Vascular Health. He's also a faculty member at the University of Reno Medical School, and we're really happy to have him joining us tonight. Dr. Rowan, we have kind of already started the conversation with Adam, our physical therapist, and kind of talked about cardiovascular exercise, aerobic resistance training and those kinds of things. I guess the questions for you is kind of, when you have patients, I imagine you kind of have two different categories of patients, those who have had a cardiac event, like a heart attack or other, and those who haven't. And so what are your recommendations for both of those groups in terms of exercise?
So in terms of exercise, I think as I heard you guys talking about, aerobic exercise is always very good. One of the things I do outside of Renown, we study a tribe of natives that live down in the Amazon rainforest. And we've been documenting their heart health the last over a decade now. And what we found is that they do about 15,000 steps a day. They're just walking everywhere. They're not running. They're not in the gym trying to run marathons or do anything really, really crazy in terms of exercise. Walking is really the best exercise for people, and we can't state that enough. 15,000 steps a day. We were able to document that group of people has the healthiest hearts in the world. They have healthier hearts than Okinawan females, Japanese people, which are known to have very good cardiovascular health. So they're really, really good shape. In terms of anything you can do to get your heart rate up, a little bit up in the low 100s, walking every day or walking on a treadmill. If you think about how many times a day people have free time where they can sit around and are on the sofa, just get a cheap treadmill, put it next to the sofa, do an hour a day on that. That's all you need to do, even for prevention. And then once you've had a heart attack, that part becomes even more critical because it's been well documented now that cardiac rehab programs that are teaching you how to do just aerobic exercises leads to less heart attacks and leads to better long-term health. And people are living longer. You'll live longer if you do aerobic exercise after a heart attack. So it's really quite simple. It's kind of like my patient that smoke. It's both easy and hard, right? It's hard to quit smoking. It's easy to say that you're going to do it. And the same thing with the exercise. It's an easy thing to do. You just got to make a commitment to do, 30 to 45 minutes a day of just getting your heart rate up.
And is there like a target heart rate that you're going for?
It depends on the age, really anywhere from 100 to 120. Just get yourself up there to a high enough heart rate. There's a lot of, if you go to the gym, there's a lot of machines that have heart rate zones they want you to get to. And that's really more for, are you targeting aerobic or anaerobic weight loss? You don't want to get it more much above 130, because after that, the weight loss benefit starts to go away and now you're burning up muscle. But lower than that, you're more in the aerobic zone and more in the the part where you're going to lose weight. But in terms of your heart's going to do fine either way. And I have a lot of patients who have Fitbits and personal heart monitors, and they really obsess about the heart rate number. And I just tell them, just don't do that, because you're going to spend more time worrying about what number you're at and really focusing on whether or not you're feeling good and you're enjoying doing it, whether or not, you use them, but don't really get. Oh,
I think we just lost you for a second. Can you hear us?
I'm just going through my dead zone right before I pull into my garage. So I apologize for that.
All right. Well, I guess the next question, and Dr. Rowan, if you need to drop off and then jump back on once you get inside, that's obviously good with us. But my next question is kind of about timing. So maybe Adam, if I don't know if you can take this in terms of, okay, someone's in the hospital, they've had a heart attack, we've got them on good medications, we've discharged them from the hospital. What are we thinking about in terms of timing, and when is it appropriate to start on an exercise program?
Yeah. Dr. Rowan talked a little bit about the importance of cardiac rehab and how the risk for having a subsequent event or all case mortality is significantly reduced. I mean, it's almost up to 50%. One session's better than none, but if you can get up to 36 sessions of cardiac rehab, if it's available to you, that's one of the best things that can be recommended. But and in general, after a patient's stable, they're in the hospital for a few days and then they're discharged home safely. We would like to start transitioning them to start doing some exercise slowly and progressively. I mean, maybe a session of 5 to 10 minutes of keeping it well below any level that has any symptoms of chest pain, lightheadedness, any nausea. That's the benefit of cardiac rehab, is you're going to be able to get a little bit more specific numbers to give you a threshold of like what is appropriate for each person individually. But getting moving is more important than anything else, just like we were talking about. So within the first week, starting 5 to 10 minutes and then progressing that slowly over time, maybe only a minute to 5 minutes a time is what's recommended, up until you're having a good workout of 20 to 60 minutes of continual exercise. So just the general parameters would be do a slow warm up and have a nice cool down so you don't stop abruptly, but working at a range where, you're still maybe able to have a conversation, but you're actually working fairly hard.
And I guess we don't have cardiac rehab specifically here in Bishop. I don't know if you've worked at a cardiac rehab program. It sounds like you have before. And so can you kind of talk about how a cardiac rehab is different, or what they focus on, that may be more a little bit different than just going to a physical therapy session like we have here?
Yeah, sure. One of the benefits would be that you're getting like actual real-time data of what your vitals are. So they're monitoring your heart rate, your oxygen, your blood pressure. They're looking at an EKG to see how the electrical conductivity of your heart is responding to the increased stress of the exercise. And from that, you can start dialing in and titrating the exercise intensity specifically to each person. So that way you're not overdosing the exercise, but you're also not underdosing the exercise, so that someone can progress as well as possible without cardiac rehab, keeping it a little bit more general and just listening to your body, that if you are having chest pain, you could check your heart rate if you have that available to you and being like, all right, at this heart rate, maybe I'm getting a little bit of chest pain. So let's dial it back 10 beats. And then that's going to be a target that we work out for a little while before we try and progress. But with all of it, starting slow and then progressing on from there.
Okay, and then a question for Dr. Rowan. Adam kind of mentioned a little chest pain. Let's just back off. A lot of us are really scared whenever there's any chest pain at all. Uh-oh, I think we may have just lost him. Oh, there
nope, I'm back. I'm home now.
the phone to computer transition.
Yeah, exactly.
So, are there, if someone's had an event before and they're in cardiac rehab, or they're doing rehab, or they're exercising on their own, Adam kind of mentioned a little chest pain, back off. That's probably safe. Are there any red flags that someone should stop immediately and seek medical attention?
Sorry, is that one for me, Joy, or is that for
Yeah.
Adam? Yeah.
All you.
So obviously chest pain. Chest pain is the number one thing you want to look out for. But what we see a lot of times when people start either cardiac rehab or they start exercising once again, they're starting to experience shortness of breath, probably if you're like a lot of my patients, for the first time in a long time because they haven't done a lot of physical activity. Being fatigued and short of breath is okay. That's normal, and we don't want to avoid that. But if you start getting recurrent chest pain, pressure, squeezing, things like that, that's something you want to look out for. Patients are also discharged from the hospital on a lot of medications that usually are new to them or different once they're discharged. And sometimes they can lower the blood pressure. So as the cardiologist in charge, we're often being called to supervise cardiac rehab. And when we do that, we're getting alerts that patients' blood pressure is 80 over 40, and then with exercise, it's dropping. So you want to make sure that your blood pressure is okay. If you're starting to get significant lightheadedness, dizziness, and things like that, stop, check your blood pressure, make sure it's not too low, alert your doctor if it is. And then any significant arrhythmias where you feel your heart pounding, 130, more than 130, so 150, 160 beats a minute would be concerning for a new arrhythmia. So let your doctor know. So I'd say shortness of breath, arrhythmias, and chest pain.
Okay.
But other than that, please enjoy the treadmill, please enjoy the cardiac rehab, and definitely get out there. And down there, where you guys live, is some beautiful hiking trails that you can just walk on, and probably one of the most beautiful places you can live in the country.
Well, and we agree, but a lot of it is high in altitude. So is there anything else that we need to take into account in our area specifically when we're at, 6,000 to 10,000 feet elevation?
Yeah, so you acclimate to the altitude fairly quickly. So if you're living at 6,000 feet, you should be acclimated. So that shouldn't make a big difference for you personally. Now, if you go from sea level to 6,000 feet, yeah, you're going to be short of breath. I would be too. So especially maybe if you get transferred from a hospital down in Southern California where it's sea level for a week and then you come back, it generally takes about a week per 1,000 feet to reach acclimation. So by, with you guys there about 4,000 feet, if you live in some of the higher places like Mammoth at 7,000 feet, give yourself anywhere from 4 to 7 weeks to really get back to it. But that's not a reason you shouldn't be exercising. You should just be aware of that in terms of your symptoms of exertional shortness of breath and whatnot.
Okay, well, this is a question for both of you because we do have, a lot of elite athletes as well in our area. So is there a risk of exercising too much? Can that damage your heart?
You want to start on that one, Adam? I'll let you field that one, and I'll come back in when you're ready.
Yeah, no, I think it's a hard question. In a previous company I was working for, we had an exercise physiologist that was working with some ultra marathon runners and ultra endurance athletes, and was talking about a phenomenon of, it's people who are running like 150 miles like in one go, talking about how there are this like top echelon athletes that have been shown that they're just like crushing their races and then kind of fall off the map where people don't really see them anymore, where they're not able to perform at such a high level that there's like an overtraining syndrome. So I can't really speak to that level of intensity, but yeah, I think anytime that we overreach, we're setting ourselves up to potentially have like a musculoskeletal injury. That's where we see like overuse injuries. And I'll defer on the cardiac side to Dr. Rowan.
Yeah, a lot of the cardiac risk is, it's lifetime accumulated exposure to environment, smoke, cholesterol, those sort of things. So by the time people have their first event 50, at the age of 50 or 60, you've sort of accumulated a lot of risk, and over exercising is not going to be the solution. There's not a lot of evidence to suggest that exercising above 60 minutes a day is incrementally better for you. So people have the idea that if I run 5 miles, it's good. If I run 10, it's better. If I run 150, it's the greatest thing on earth. And you certainly have a loss of benefit when you start exceeding too much exercise. And that's something that I think we don't emphasize nearly enough. Again, just simply getting out and getting your heart rate up in terms of walking is better than nothing. And walking, if you can't run, which, most of my patients have enough orthopedic issues in terms of back pain, knee pain, hip pain, they can't do it. And it's just unrealistic to ask them to do that. The ultra marathons, when I lived in Seattle, we used to have a ton of older patients, older marathon patients, 50 years old, that were having their first heart attack. And they were kind of dumbfounded as to why this was happening to them. because they had lifestyle wise done everything that they thought they could do to ever avoid this problem. The problem with that mentality is you're ignoring the genetic component to heart disease, which we know there's a very high impact of what your genes do to your cholesterol and your cardiac risk. There's a new emerging marker called lipoprotein A, which is a cholesterol-like particle, which seems to carry a lot of risk for patients. That's a 100% genetically determined. If I check your lipoprotein A levels at the age of 8 weeks versus your age at 80, they're basically going to be exactly the same. And there's nothing you can do lifestyle-wise to run or change your diet to affect that. The reason we're knowing more about this now is there's some drugs that are in the pipeline that'll be out in the next probably 2 years that can fix that. But there's certainly a lot of very strong evidence that that's a risk factor for heart disease. So again, this is a little bit predetermined in the sense that, the genetics of this is the underappreciated part. And although exercise is really, really good, if somebody has a heart attack, don't spend a lot of time blaming yourself saying, I did this to myself by not running enough or not being active enough.
And so statins don't do anything to lipoprotein A?
Very, very little, almost nothing, probably less than 1%. Now there is Repatha and Praluent, which has been shown to lower the lipoprotein A levels a little bit, maybe 10%. But there's some drugs on the market that should really probably lower them, 90% that are coming online here probably in the next year or two. And we're involved in a few clinical trials here at Reno looking at those specific medications.
And for those who haven't heard of Repatha, can you kind of talk about what that is?
Oh yeah, so for people who are statin intolerant, who can't get on them because of muscle aches and pains and joint pains that are seen in about 2 to 5% of statin patients, Repatha and Praluent target a different pathway of cholesterol metabolism. They're once every 2 weeks or once every month injections of an antibody that makes you reabsorb the cholesterol much quicker from your blood, and they generally don't cause the side effects that statins do. And they're very, very powerful drugs. You have to lower your LDL, the low density lipoprotein or the bad cholesterol, 50 to 70% in some cases. And I've had a few patients who come back where their LDL cholesterol is now actually undetectably low. And a lot of their doctors are saying, oh, we need to stop that because your cholesterol is too low. Well, it turns out there's not a lot of evidence that having too low of a cholesterol is bad for you, believe it or not. And there's a genetic disease where people have cholesterol levels that are undetectably low. They were found by mistake. They just found a cohort of people back in Pennsylvania that had this genetic defect where their total cholesterols are less than 10 with an LDL under 3. If you can, for Joy, who probably sees these numbers a lot, that's incredible. A normal LDL in the population is like 105, 110. These patients are running around with levels of like less than 3. And what they found is this whole family of people with this genetic defect have absolutely no long-term health consequences cardiovascular wise, and no other problems. They get big lymph nodes, but that's about it. And they don't get a higher rate of cancer. They don't get in fact, they get absolutely no plaque in any major arterial bed. They're absolutely fascinating, but it reinforces the point that the LDL level, the lower we push it, the better off people are going to be.
Well, for those of us who do follow cholesterol level, total cholesterol, HDL, which is that good cholesterol, LDL, which is the bad cholesterol, I've always been taught that more exercise increases your HDL. It's good to have high HDL. It's protective. Is that true? Or?
It's true. It's also true. It's also very hard to make sense of it. And the latest literature in the last few years is suggesting maybe the HDL doesn't provide as much protection as we think it does. And there have been a number of drugs in the market in the last, say 10 years now that raise HDL, but every time the drug raises the HDL, it doesn't change the risk of a future heart attack. And so as I explained to people, it changes a number, it doesn't change your outcome. And that's a hard thing to wrap our head around because we say, well, the number equals the outcome. And it's like, no, the number equals the risk. It doesn't equal whether or not you have a heart attack or stroke. And so for a long time, probably back 10 or 15 years ago, we were pushing niacin on people, if you remember that. Niacin causes that terrible flushing reaction. You turn bright red. It feels like you're on fire. And we're pounding people, got to stay on this drug because it's good for your health. Well, it turns out niacin actually increases pneumonia, brain bleeds, GI bleeds with absolutely no benefit in terms of recurrent heart attacks. So what we were telling people for years is, of course, wrong. And that goes along with that HDL, which is, it doesn't really seem to be that powerful of a player.
And kind of piggybacking then on cholesterol, maybe we can change gears a little bit to talk a little bit about diet. I know neither of you are dietitians, but I'm sure both of you get asked a lot about, well, what diet could, I'm now on a great exercise program. I want to get on a good diet. Is paleo good? What about intermittent fasting? What supplements? What vitamins? I mean, I'll kind of put it to you, Adam, first to see what your thoughts are about that. And then if Dr. Rowan can follow up.
Yeah, I think I just try and keep it simple, like eat real food. See what the low-hanging fruits are. Do you drink soda regularly? Try and cut back on that. Like, what's your alcohol consumption? Is there any wiggle room for choosing a few things in your day-to-day that you can start trimming back on? I mean, major life changes are pretty hard. So like, what's doable, what's agreeable, and what's actionable? Let's look at what you do and pick a few things and do it.
Yeah, exactly. And the one of the cardiologists at the American College of Cardiology, he just has a very simple saying. He says, eat small meals, less often, mostly plants. Now, that's hard to do, especially in a lot of people who are just programmed into eating a lot of meat. There's a lot of stuff on the internet about, if you eat game meat or stuff that you hunted, it's better for you. If you did this, it's better for you. It's absolutely not true from a medical standpoint. Lord help you, I wish it was true. But it just turns out not to really carry a lot of evidence. The best diet with the most amount of studies behind it to improve cardiovascular health specifically is the Mediterranean diet, which is a lot of low starch vegetables, fish, cutting out your meats, and certainly cutting out your saturated fats, which carry a lot of your risk. In terms of when you go to cardiac rehab, they stress a lot of vegan diet. Now, they don't expect you to become a vegan, and this is where the messaging, I think, gets lost for a lot of patients, which is they say, I'm not going to become a vegan. And, I say, I don't expect you to, but the more you head in that direction, the better you're going to be. And, unfortunately, as Adam's saying, processed foods. Now, here's where the inflammatory hypothesis of heart disease starts to come into play. Is a lot of those processed foods have chemicals in them that are not naturally metabolized by your body. So specifically, if you think about the trans fat issue that was going on in New York City and New York State maybe 10, 15 years ago, there is no natural enzyme in the human body that metabolizes trans fats. So there's no way for your body to process them into smaller fat molecules. As a result, when your what are called the macrophages, or the immune cells, see that, they look upon that and say, oh, this must have come from a foreign invader, like a bacteria or a fungus or a worm, and they start producing all these immune inflammatory markers, and then they wall that off and try and create a shell around it to isolate it, and that becomes a plaque in the arteries of the heart eventually, and that leads to long-term heart disease. And a lot of fats that are seen that are sort of not naturally occurring or produced in a lab, so to speak, also create that same reaction. And that's where a very simple rule of thumb, like Adam says, is normal natural foods. Now, you also said supplements.
Yeah.
That's a tough one because, the vitamin industry is a, 30 or $50 billion industry in this country. Unfortunately, most of them don't pan out in terms of the benefit to the heart. And a lot of them claim to have evidence behind them. Now, when we talk about evidence for a vitamin, they'll say, I studied 10 people, I put them on the vitamin, I didn't have a placebo arm I compared it to, and of the 10 people I followed for 4 weeks, here's the results on 3 of them. That's a pretty weak outcome. Now, when we study drugs in medicine, we look at 5,000 people on a drug, 5,000 people on a placebo. We study them for 5 years, and we look at all the safety endpoints in terms of harm the drugs can do and all the benefits. So we've never seen that in any real vitamins. You probably never will. And the ones that they have tested seem to then create a lot of controversy, because like when we looked at niacin, which is considered a vitamin, we found a lot of downsides.
Very good. Well, I see that there's a question from Ann Wagner. So kind of shifting back to exercise, she asks, are there any limitations as far as aerobic exercise or hiking at altitude? We kind of talked about that following any kind of open heart surgery. specifically like an aortic aneurysm repair. So probably
That's a very
about blood pressure and other things.
So like any major surgery, or the analogy I like to use is like you broke a bone, you need a few weeks to let that heal, right? So if you broke your leg, Joy, or Dr. Engblade, excuse me, I wouldn't have, if you break your leg, I wouldn't say here's some Tylenol and tomorrow go running. You got to have it 6 to 8 weeks for everything to heal in place and give your body a chance to go back to normal. Now, after an aortic aneurysm repair, if it's a fully repaired aneurysm, you should be able to go back to full exertional exercise by that 8-week point. Now, if it's a thoracic aortic aneurysm, we'd probably put you into cardiac rehab if you're in the local area. For an abdominal aortic aneurysm, which is a different thing entirely, we replace the aneurysmal tissue with essentially a plastic graft. So that weak part then goes back to normal, and you should be able to go back to doing whatever exercise you want. In terms of altitude, the altitude doesn't place any additional stress on the vascular system. It does place stress on you in terms of shortness of breath and acclimating to altitude. And so, if you're doing that, just, kind of listen to your body. Don't get any chest pain. If you're getting, so short of breath, you can't keep up with everybody, just slow down. There's nothing wrong with that, or don't push it that hard.
Right. Does anybody else have any other questions? Feel free to put it in the chat or just unmute yourself and ask your question to our two experts here.
All right. See if I'm in there. John Patzer is right here in Bishop. After having a heart operation where I had a heart murmur, it was a heart roar with one of the flaps going the wrong direction. And I don't have any support up in Reno. I did all the preliminary tests there in Sparks, but wow, fighting snowstorms and stuff. Anyway, got on the line, checked in LA, and I had a doctor, Ben Harish, a surgeon, available in UCLA. So I ended up in there, and I spent over a week in the hospital. They were worried about my heart being out of sync. And now I've been 6 weeks, and they finally let me get in the front seat of a car because they're worried about the airbags, which we have. One of my friends here had a tangle with his pickup truck and damaged his sternum that was perfectly healthy. Now I'm back in Bishop for the second day, and what treatment do we have at Northern Inyo? I went into the hospital today, and mainly I'm on Coumadin, and they're trying to monitor that level with blood samples, and they're gonna call me back when they figure out. I just thought I heard you had cardiac physical therapy. They had one through Nolan Healthcare coming to my house now and then. When I was down, I was in Huntington Beach. And the other thing is, I'm on the Coumadin and something else with an A that is a heart stabilizer. And I finally researched that today. It says that can cause lung damage and ruin your liver. So I'm hunting for a follow-up here in Bishop. So that's the long way around, is what do we do now that I'm home?
Yeah, I would imagine the drug that starts with the A is a drug called amiodarone. And like all drugs, it has toxicities that we have to monitor for. Now, generally, the lung and liver toxicities are only seen at higher doses. So usually if they discharge you from the hospital, they're going to put you on about 400 milligrams twice a day, but only for about 1 to 2 weeks. After that, they're going to put you down to a maintenance dose of 200 milligrams once a day. At the 200 milligram dose, the incidence of cirrhosis is almost unheard of. I looked this up the other day because I had a patient ask me the same thing. Essentially, there's no evidence that amiodarone causes cirrhosis. There's a few cases in the literature that say for people on amiodarone, they developed cirrhosis, but it's not clear it was the amiodarone. Drinking and other things, hepatitis C that causes cirrhosis. But truly the drug itself causing that problem is almost unheard of. In terms of the lung disease, there's a disease called interstitial fibrosis that patients on a very long exposure chronically at high doses of amiodarone has been reported, but at the maintenance dose of 200 milligrams a day is very rare. So, certainly don't let that dissuade you from that at all.
And Adam, can you speak to, what we would be able to offer from a physical therapy standpoint?
Yeah, anytime someone who's in a hospital for an extended period of time, we lose strength and functional capacity. So if you're feeling like you're having a hard time getting in and out of bed or getting back to the activities that you want to be doing after a short-term stint, please let us know. Contact your primary care provider and get a referral to come over and work on some strengthening. We can also address some paced cardio return to full activity as well. We'd love to work with you.
All right, seems quiet. One of my things I do regularly is hop on my bicycle. I'm on the way west side of town. Go down my street, through the field, through J Diamond Trailer Park. The risky part is getting across Main Street,
Right.
through the park, and then over to the senior center for lunch, which is now closed for 2 weeks to redo the kitchen. And that is the minimum. And the senior center, they have a dietitian. They've got the fresh salads, the fruit, the main course. So, and I've had no symptoms really. It's just they're saying, hey, you ought to do something, get it while you're not too sick. If you're going to open up your chest, get it while you're still healthy. So, and boy, that was awakening. I packed baggage for a week, maybe 2, and to spend 6 weeks with my niece down there. Surprise! But oh well, thank you for the advice.
And then Joy, it looks like somebody's got their hand up. You have Yvonne?
Yes, that's me, Yvonne Katzenstein. I'm just curious. I had a heart attack back, probably about 15 years ago. But I'm very curious about stress in relationship to having had that heart attack, and anything that I need to be paying attention to as far as stress in my life, meditation, or anything that as far as is helpful with heart issues.
Yeah, that kind of goes back to the idea of the cardiac rehab. Anything you can do to minimize the stress in your life is always going to be beneficial to you because that'll lower your blood pressure and lower your sort of over anxiety as well. The influence that stress has on your risk of a recurrent heart attack is small but measurable. So, a lot of the stress comes from things like family, finances, talking politics with families at family gatherings or holidays, and some of that stuff just isn't avoidable. So minimize it as much as you can, but it's not the panacea in terms of minimizing your recurrent risk. The real thing you want to do is focus on, good diet, exercise. Make sure you're continuing to take your medications, get your cholesterol down, get all your risk factors under good control.
Yeah, I would say I do know that getting appropriate exercise is very helpful in managing my stress too. So I've always been curious if there's a separate component that stress plays, and especially in the initiation of a heart attack originally, because it was a very stressful period of my life. And I don't know, just curious about overall the impact.
It's an interesting thing. There's a phenomenon called a stress-induced cardiomyopathy where for some reason, and actually seen most commonly in postmenopausal females, where for some reason out of nowhere, the heart becomes stunned and develops a transient heart failure syndrome that's very, very stereotypical in what it looks like. And most of the time we can't figure out, we really don't understand what is causing it. We don't understand why, and we don't understand how to prevent the recurrence of it. But it's related to stress. And so patients who, I had one patient who came out of their house and saw their neighbor's house was on fire. That sort of level of stress, in terms of, I missed my power bill last month. It's probably not enough stress to cause it. But in about 40% of cases, we also never see a precipitating stressful event to cause it. But you're right. It's interesting that the mind certainly has an effect on the health, and we downplay that, I think, a little too much.
Okay. Thank you.
Anything to add from exercise or physical therapy standpoint related to stress?
Yeah, something that comes to mind is as trying to make sure that we sleep well. I was just thinking how the link between sleep, stress, exercise, and physical and mental health all go together. And it's a question that I kind of want to ask back to Dr. Rowan as far as how sleep is affecting our cardiovascular health, even things like screening for sleep apnea.
Mm-hmm.
Oh yeah, fantastic question. And it's also been shown that patients that are shift workers at night have a higher incidence of heart disease. Now, that's not clear if it's the behavior associated with working nights or if it's the cause of the night itself, but it certainly makes you think that, getting a good night's sleep and being in that normal diurnal pattern that sort of evolutionarily we're programmed to is very, very important. In terms of unmanaged sleep apnea, the risk of atrial fibrillation, the risk of strokes, the risk of all the health problems that come with that, and heart attacks with untreated sleep apnea is just very well documented at this point. Also, high blood pressure, and the other thing that's interesting is one of the things that sort of gives you a little bit of stimulation is high sugar or high carbohydrate foods. And so patients with really bad sleep apnea have a tendency to sort of crave that all the time to kind of keep them awake. And so once patients who have severe sleep apnea get treated for the sleep apnea, they find that a lot of their cravings get better. And sometimes they actually lose weight. So yeah, that was a great question, Adam.
The other thing I was wondering about too is, well, just the timing of the exercise. I found as I've grown older that if I try to do something aerobic at night, so like riding the bicycle machine I have, I can't sleep that well. And I don't know if that plays into some of the issues too that arise with having a heart disease.
I've noticed the same thing too. If I go for a long time without exercising and I do something really, really vigorous at night, my adrenaline is so ramped up when I go to bed, I don't sleep well at all. So I've noticed that, but I don't think anyone's actually ever studied that. That's an interesting question.
If you look up like sleep hygiene, it's one of the recommendations is like limit your exercise later in the day, try and get it done earlier in the morning. So yeah, I've heard that that's a factor as well for preventing a good night's sleep.
Okay. Yeah. And I will say, I've had sleep apnea since my 30s, and just recently got a CPAP machine, and I just have noticed that it's sort of like a miracle in many different ways in my life. So I wish I'd been doing that much sooner in my life, especially hearing what you're saying about association of sleep apnea with heart attack.
Yeah, but you're treated now, so
Yeah. Yeah. I'm thankful about that.
Well, thank you for all those questions. Great questions and great points. And the next time I need a poster child for sleep apnea and wearing CPAP, Yvonne, I'm going to call you and have you talk to them.
Okay. I'm happy to do that.
All right. Well, we're at about 6:15, and so we'll start to wrap up. If there are any other questions, happy to take them. Otherwise, thank you to Dr. Rowan. Thank you, Adam. This has been really interesting. I learned some things. Lipoprotein A, I'm going to start following that, Chris, and make sure that that's on the radar. That's super interesting. I think that we kind of talked about really it's just get out and move and do whatever you like to do. And if you had an event, do it gradually. No need to be excessive. You're going to get the health benefits without having to be excessive. Eat real foods, whole foods, not processed foods. All the rest of the fancy diets, but Mediterranean diet, if you're going to pick one, is probably the one to go with. So that's kind of my takeaway. Do you guys have anything else to add or any last words?
No, that's a great summary, but I like what you said is, just get out there and move and do whatever it is you like to do, but, get the heart rate up and be active.
Yeah. I love the point of not overcomplicating it, doing something that's simple, but hard. It's easy to do, but it's hard to do. We can all just recognize that limitation of overcomplicating it or making excuses, but it just comes down to doing it. And that's hard to do, but it's easy to do.
I love it. All right. Well, thank you everyone for joining. I don't know, Barb, if you have everyone's contact information available, but obviously Adam is one of our newer physical therapists, but our rehab department is always happy to see new patients. We do have a cardiopulmonary department here. Dr. Rowan doesn't officially work here yet, but we're working on that. But we're able to do cardiac testing. We often call Dr. Rowan for any help in interpreting any kind of complicated tests. And so please reach out to us. We're here to help serve our community. So thank you and have a great evening. Thanks for joining.
And be safe in the weather coming up.
Yeah.
Have a good night.
Thank you very much.